name is Paul Wesson. I am one of the co-directors for our scientific working group on intersectionality, and it's my pleasure to introduce our spring symposium. We have had a great launch year as one of the newest scientific working groups within the CFAR. Our overarching goal with the creation of this, what we call a SWGI, a scientific working group on intersectionality, was to co-create a scientific community here at UCSF for investigators to learn about and receive support in incorporating intersectionality into their scientific inquiries. At our launch event last November, we highlighted newly funded research by one of our junior faculty members on how intersectional stigma and discrimination lead to inequalities in HIV treatment outcomes for racially diverse women living with HIV who use drugs. And earlier this year, we hosted a thought-provoking community panel to hear community perspectives on how intersectionality manifests for them and what academics should keep in mind when incorporating intersectionality into research. Today, we are very fortunate to be joined by three esteemed national scholars who think critically about how to rigorously apply quantitative methods to study intersectionality. In fact, when I was talking about the symposium to some of my colleagues yesterday, one appropriately asked what would be discussed today beyond interaction terms. And I have not yet seen the presentations, but I'm excited for a very rich discussion that I imagine will challenge us to think about how to quantitatively capture the complexity of people's lives beyond an interaction term. We've asked each of our panelists to give a presentation on their research for about 15 minutes, followed by about 5 minutes for questions. And then in the last half hour of the symposium, we will open it up for a full panel discussion. So please feel free to type your questions into the chat. And with that, I will turn it over to our director, Dr. Anissa Fuente, who will introduce our first panelist, who is Dr. John Jackson.
Hi, everyone. Welcome. And so nice to see you all here with us today. So Dr. John W. Jackson is going to be our first speaker. And Dr. Jackson is an assistant professor in the departments of epidemiology, biostatistics, and mental health at the Johns Hopkins Bloomberg School of Public Health, and is also core faculty in the Johns Hopkins Center for Health Equity, Center for Health Disparities Solutions, and Center for Drug Safety and Effectiveness. So Dr. Jackson's research primarily focuses on developing methodological tools for translational health equity research, some of which we hope to hear about today. And this includes methods to identify high leverage targets and strategies for interventions that address health disparities, as well as new methods to evaluate effects of interventions and policies, and also how to translate interventions to new populations and contexts. Dr. Jackson's work has been funded by the National Heart, Lung, and Blood Institute, as well as Johns Hopkins University. He's a member of the editorial board of epidemiology, as well as sociological methods and research, and we're very excited to hear from him today. And with that, I will hand it over and welcome Dr. Jackson.
Thank you very much for having me and for this introduction. Let me share my slides. Please let me know if you can you see it? Okay.
Perfect.
And if I move to the next slide, let's see here. A second, let me do this for okay. Screen. Okay. Okay, there we go. And then, all right. So thank you for having me here today. I'm going to be talking about a conceptual model for measuring disparity. And I know, we often think about needing to focus on interventions, but I think this is really fundamental and foundational. A lot of my work in intersectionality, I've focused on the issue of intersectional disparities, and so that's the frame with which I'm pursuing this talk today. And so this conceptual model I've been thinking of, I'm advocating for in the place of various causal models for disparity, and I'll talk about that later. And I think the model has special relevance for measuring intersectional disparities on health, as it centers on capturing what is when it comes to matters of injustice. I'd like to acknowledge my collaborators in this work. And I have a lot to cover, so I apologize in advance that I'm going to have to move quickly, but we can always talk more about it in the discussion. I'll start by briefly reviewing key points about common definitions of disparity. I'll introduce the descriptive model, what I'm calling an observational target trial. I will also talk about issues of selection, what some have thought about as selection bias, and close by arguing why such a descriptive model is extremely useful. There's a lot to cover here, but we've written this up. It's posted on archive and currently under review. It's currently under revision, so comments are welcome. And while I don't have time to cover the extensions, it essentially serves as a foundation for causal inference. So using analyses of observational data to inform interventions, which I call causal decomposition analysis. That's the second paper. And then it also underpins analyses of actual intervention and policy effects on disparity and intersectional disparities, which there's a working paper that's under review. So I want to start by emphasizing that measurement matters. It's important for benchmarking progress towards equity, but measures don't have meaning on their own. They often need an underlying story to make them relevant for action. Measures are often built through a host of decisions, and having a conceptual model can help with those decisions, make them coherent. So the goal for our model is to be inherently feasible, incorporate norms and values regarding equity and justice, and reflect the fact that in many cases, especially in matters of health, we're dealing with selected populations. I usually start my talks by being clear on at least what I mean when I'm discussing disparity in public health and medicine. So the IOM definition says that disparities in healthcare are differences in healthcare that are not due to differences in clinical need or other relevant factors. These factors are often ruled out and conceived of as being allowable factors. The Healthy People Report definition, advanced in large part by Paula Braveman, says that disparities are plausibly avoidable differences in health across socially advantaged versus disadvantaged groups, where the disadvantaged group is further disadvantaged with respect to health. That definition takes the perspective of human rights, that all persons are entitled to optimal levels of health or a minimum threshold of health. And so the injustice of a disparity doesn't lie in its underlying cause necessarily, but also in its effects on disadvantaged groups. Finally, the National Institute for Minority and Health and Health Disparities has their own definition, which clarifies that even unjust disparities can have complex etiologies involving the embodiment of disadvantage and interactions with biology, and that disparity can be measured at various life stages or within the course of a disease. So here's the big takeaway. If you get lost with some of the formulas and stuff, the big takeaway, so the model, I'm calling it an observational target trial. It's essentially an inception cohort with naturalistic follow-up, builds on the target trial framework for treatment effects. In that line of thinking, someone might be eligible for a study or a trial at multiple points in their lifetime. We would consider all such trials and pool their data over time to be more efficient. Rather than comparing treatments, we compare privileged and marginalized groups. There's no randomization of who belongs to which group, but rather we enroll people through a sampling design that produces balance for certain characteristics, i.e. allowable characteristics like clinical need, if we were measuring disparity in treatment outcomes. So essentially, these groups are similarly situated in a distributional sense on the allowables. Then we follow them over time and compare outcomes. When we deal with selection, selective mechanisms can be conceived of as contributing to disparity if we think that they reflect some form of injustice. Otherwise, if we think that these mechanisms mask other sources of disparity, we can remove them. Now, when we move to remove them, we move from description to causal inference in the sense that we need to consider some hypothetical intervention on some or all of the eligibility criteria themselves. Now, I'm going to go through these elements quickly, touch on selection, and then talk about the underlying motivation. So to zoom in, we start with a source population that's well-defined. We pick out a marginalized and privileged group, each of which may be each of which may be intersectionally defined across two or more axes of disadvantage. Second, we think about our population of interest, which captures issues of scope and also issues of timing during our life course or diagnosis. Once we've decided on the criteria, we assess eligibility within each unit of time. Then we consider what variables, if any, we would like the social groups to be similarly situated on. Allowable covariates are those whose differential distribution is not thought of as contributing to what one thinks of as disparate outcomes. A common example is clinical need with respect to disparities in healthcare or disparities in treatment. Essentially, we want these allowable covariates to be measured by the time eligibility is satisfied, whenever it is satisfied. And there's not much formal work on how to choose which covariates should be deemed allowable, but Jackson, the paper that I referenced earlier, that's in epidemiology, published in 2021, provides an overview. And hoping more people will do work in this space. The enrollment process concerns two stages of random sampling. The first stage concerns selection into the eligible population. For now, we can just say it's simple random sampling. The second stage balances the allowables across social groups by use of a sampling fraction that produces a population where the distribution of allowables, for example, clinical need, of each social group follows the same distribution. And that distribution I'm going to call the standard distribution. Now we have to choose what this standard distribution is. In the model, the standard distribution comes from a within sample standard population. We can choose the standard population to be the marginalized group, which centers the experience of the marginalized group. And if we do this, then we're taking the observed outcomes of the marginalized group, comparing them to the standardized outcomes of the privileged group where they have been standardized to have the same distribution of allowables as the marginalized group. Other choices can be made, but I believe that this choice centering the marginalized group is one most consistent with intersectionality. And in this model, we have a clear sense of when follow-up starts, and that's at the final point at which eligibility is satisfied. We also have to decide when to measure outcomes, what those outcomes will be, and for how long we're going to assess them. So if we could conduct a trial in this way, where the allowables were balanced by sampling through the enrollment process, a simple comparison of difference within the trial would reflect disparity. But even descriptive trials like this may not be feasible. They may even be unethical. So we can try to emulate them with data for the purposes of measurement and also for causal inference. Here's a summary where we start with the data, we subset the data to the social groups of interest, assess eligibility for each person across all units of time. Then we select a time 0 for each eligible time. And then for each eligible time, we choose allowable covariates measured at or before the point of time 0 for each eligible time. And we balance those allowables by weighting or by G computation. And we can get confidence intervals analytically or by 95% or by bootstrapping. I won't go into the technical details, but the analytic methods should be familiar to at least some. We can use a variation on inverse probability weighting to balance the allowables in our emulation, which requires modeling the statistical dependence of social group membership on the allowables. We can also use model-based standardization to balance the allowables as well, which involves modeling the outcome statistical dependence on the allowables. Depending on our eligibility criteria, people might be eligible at different points in time. For example, we're thinking about disparities in care. People may have multiple relevant points of care, or different people may have have care episodes at different times. In our model, we take all the points at which a person is eligible, which allows us to have more power, which is important in this type of research. And in doing so, we want to treat time itself as an allowable covariate. And there's a few points on why this is important. One, disparity is a population metric. So populations are defined at specific points in time. So in most cases, we don't want to compare groups from different points in time. Two, considering time as allowable allows us to interpret the estimate as a weighted average of time-specific trials or time-specific studies, wherein the distribution follows the experience of the standard population, which in our case, we've chosen to be the marginalized group. If a person meets eligibility at different points in time, we can select one trial per unit of time, perhaps randomly, and then pool all the selected trials, again, treating time as an allowable covariate. This helps us produce disparity metrics that meaningfully summarize the population experience over time. And of course, we could always report trends over time as well. So a conceptual issue with disparity measurement that's often been lurking in the background in epidemiology journals is the issue of selection. So there's a lot to say here. For lack of time, I'm going to completely skip over the issue of representativeness or generalizability and just discuss the case where we have a meaningfully defined population. I know that's a huge omission, but there's a subtler issue I want to focus on here. The issue is collider stratification. If we think about the data generating process from a causal perspective, we can see that some of the disparity will arise from how people are selected into the eligible sample. This doesn't have to do with representativeness. Rather, through collider stratification, it's an induced correlation because of how selection affects the distribution of non-allowable covariates, which then go on to affect the distribution of outcomes. And in the paper, we argue that selection, when leading to a disadvantaged distribution of non-allowables for the marginalized group, we can think of those mechanisms as contributing to worse outcomes among the disadvantaged group, and thus being a part of disparity. And if you have a meaningfully defined population, there's no selection bias at all. The selection itself is part of the disparity. However, if the selection mechanism leads to more favorable outcomes, you can still think of it as a real mechanism. However, one that might mask disparity from other sources, such as discrimination. And in that case, we might want to actually remove the impact of selective mechanisms from disparity. And to do that, we can modify our conceptual model slightly. We can still treat the groups descriptively, so we don't intervene to change what social group a person belongs to. Rather, we intervene to set the eligibility criteria so that at most they depend on what we've chosen to be allowable, if anything, and also what social group a person belongs to, and perhaps other eligibility criteria as well. And such a counterfactual source population restricted to the eligible population won't produce the type of selective impacts, i.e. collider stratification, that we are concerned about. In other words, if we conducted a trial in this way, the selective mechanisms would not contribute to disparity. So in our model, we accomplish this by first changing the first sampling stage fraction from simple random sampling to a sampling fraction that delinks the non-allowables from eligibility. In the paper, we discussed that you can be more subtle and only delink the non-allowables from certain eligibility criteria, not all, under various causal structures, which I don't have time to get into, but I would see the paper for more details. And we have weighting and also model-based standardization emulators for that extension. So now I'd like to talk about why a descriptive model is a really useful contribution. Historically, I'd argue that medicine, public health, and economics and sociology have generally been enamored with causal measures of disparity. By causal, I mean disparity that's defined by changing what group a person belongs to or by manipulating the distribution of the allowables. In the first case, we would intervene at birth to change someone's identity or whenever that identity manifests. In the second, we would intervene to change, say, clinical need, which for treatment disparities, we may have conceived of as allowable. You often see the latter in the case of health services research and also health economics, and both forms of causal disparity show up increasingly in fairness metrics that have been proposed to mitigate algorithmic bias. Now, why have we been so taken by causal measures of disparity? I don't know the exact answer, but I think it goes back to a particular reading of disparity definitions that prioritize experimental evidence and knowledge generation. For example, in the Institute of Medicine definition, it says that disparities in healthcare are differences that are not due, i.e. not attributable to differences in, say, clinical need. I think that many people with training in causal inference read this phrase due to as an attempt to rule out by experiment. Certain circumstances, I think experimentation suffices, but I don't think it's necessary. In fact, I think a much more feasible reading would be to do what we do in real life to balance the allowable situationally. That is to construct a sample where the social groups are similarly situated on the allowables by comparing those with similar need. In fact, such descriptive studies were used to motivate the experimental models, which ironically abandoned the idea of description. Another reason people favor causal accounts is under the premise that causal attribution automatically entails more obligations. I think that's a reasonable view to hold, but I think this reasoning doesn't apply to causal measures of disparity. The root cause of disparity is not the actual assignment of what group someone belongs to or the values of the allowables, but rather structural forms of injustice that produce the social group assignments, their positioning in social hierarchies, and also produce the distribution of the allowables. So given this deeper account of causation, the causal measures of disparity have a very limited sense of causal attribution. However, acknowledging the moral obligations to address structural racism and other forms of structural disadvantage doesn't require that disparity measures need to be framed in terms of causal actions on structural injustice. There are other accounts that find more problems even with descriptive differences in outcomes among groups. These accounts highlight the importance of human rights, the importance of reparations, and the impact that disparate outcomes have in well-being and other dimensions in life. Furthermore, I want to point out that disparity as causal paradigm, and to use strong language, actually disrespects what we know about how injustice works. We know that mechanisms of injustice are interdependent, mutually constituted, and dynamically reinforcing. But in order to get the math to work, most powerful causal models ignore such realistic processes. I really question the measure of injustice that must assume away key elements of injustice. It's true that all models are wrong and some models are useful, but when we have descriptive models of injustice, I don't see the need for causal measures of injustice with these limitations. I only have 2 more slides and I'll wrap up soon. I would also point out that a descriptive model has practical benefits. There's no need to agonize over the correctness of the causal model. In fact, if we had to do this, it would make the practice of using measures of disparity to motivate social action exponentially more difficult. And finally, a descriptive model of disparity turns our attention away from causal semantics to things that matter. Who is centered, who is compared, what should groups be similar on and why, how long are we talking about following for outcomes, and what do we think is a population? And the nice thing is that we can build on causal inference on top of these descriptive measures. In essence, we save the causal inference for when it matters most, informing interventions and evaluating those interventions. Thank you very much for your time, and I look forward to the rest of the talks.
Thank you, Dr. Jackson. I think we have just a couple of minutes for questions. Does anyone have a question? And we will have time for discussion after all the presentations.
Well, I'm happy to talk more later. I know that was a lot.
Yeah, there's a lot for me to try to digest. But am I correct then in sort of summarizing that when you're comparing the most disadvantaged group or a disadvantaged group to a privileged group, your allowables are things that have that don't play into that disadvantage, but there's not variability between those two groups. You're using that to standardize the groups, and then so that the difference between those groups are what you're calling the non-allowables, which are the variables or factors that are contributing to the disadvantage between those groups, and then seeing what the difference is between those groups.
That's correct. That's correct. And in this model, you don't have to specify what those non-allowables are. And the subtle differences between like a descriptive model and a causal model from the math's point of view is just saying what should that distribution of non-allowables be. And so I think a descriptive distribution actually is more based in reality and less reliant on causal models that have strict restrictions on how things operate. And so, yeah, and to get to your point about allowables, you're right. Like these are differences that we might not conceive of as being disparate. And so for treatment, when we're talking about treatment, I think that's a really easy one for people to pick apart and say that, you know, obviously clinical needs should be, allowable because we want to, see disparate differences. When you get into treatments that, there are scarce resources and everyone needs it, and then there are sort of like rules that are put in place for allocation, you could conceive of those as non-allowable, actually, I think. So yeah, we can talk more about this later, but it's interesting. This idea of allowability goes back decades, but very few people have really thought about like what should be allowable and when. And so I'm hoping that we can have more work in this area. And I think the matter becomes much more interesting, but also more complex when we talk about intersectional disparities.
Great. Well, maybe we can revisit that during the panel discussion then.
Yes, there's one more question in the chat before we move to our next speaker, which is, did you mention that a paper was currently being written about this presentation, or are you showcasing a specific paper?
Yes, it's on arXiv, and I can put the link in the chat.
Fantastic.
Yeah, hopefully within the next month, there'll be a new, better version up, but if you want to read this version, you can do so.
Great. With that, I'm going to thank you again, Dr. Jackson, and hand it over to co-director Orlando Harris, who's going to introduce our next speaker.
Thanks, Anissa. Good morning, everyone. Our next speaker is Dr. Dustin Duncan, who is an associate professor in the Department of Epidemiology, and his new title is the Associate Dean for Health Equity Research at Columbia University Mailman School of Public Health, where he directs Columbia's Spatial Epidemiology Lab and co-directs the department's Social and Spatial Epidemiology Unit. Dr. Duncan is an internationally recognized social and spatial epidemiologist. His research broadly seeks to understand how social and contextual factors, especially neighborhood characteristics, influence population health. Dr. Duncan's intersectional research focuses on Black, cisgender, gay, bisexual, and other sexual minority men and transgender women of color across the African diaspora, including the United States, the Caribbean, and Africa. His work appears in leading public health epidemiology, medical geography, criminology, demography, and psychology journals. Working in collaboration with scholars across the world, he has over 200 high-impact articles with more than 120 as first or senior author, book chapters and books cited over 8,100 times. His research has appeared in major media outlets, including the U.S. News and World Report, the Washington Post, the New York Times, and CNN. Dr. Duncan's recent work has been funded by the National Institutes of Health, the Centers for Disease Control and Prevention, the HIV Prevention Trials Network, the Robert Wood Johnson Foundation, Verizon Foundation, and Aetna Foundation. He has received several early career and distinguished scientific contribution, mentoring, and leadership awards, including from the National Academy of Medicine, the Harvard University T.H. Chan School of Public Health, and the Interdisciplinary Association for Public Health Science. Dr. Duncan, it's a pleasure to have you, and the floor is yours.
Thank you so much. I'm going to share my slides as well. Give me one moment, please. Can everyone see them well? Okay, awesome. My talk is different than John's. It's a little bit more conceptual, and it's something that I've been thinking about building on my experience last summer, actually being a participant in the Intersectionality Training Institute. And it's really helping us think through why I think we need to think from a multi-level perspective. So there's less math and it's more conceptual. It's a little bit more foundational. And I have some thoughts afterwards in the question and answer how we could think about approaching this in various quantitative ways. So the title of today's talk is Intersectionality in Health Research, Importance of a Multi-Level Intersectional Perspective. So just first, as we think about or remind ourselves about intersectionality, when we frame what intersectionality is, we remember that we highlight the importance of, we call them structural identities, gender, race, class, etc., and how these different identities really interact to produce expressions of privilege and power in society. In my first work with intersectionality, including some early paper with Lisa Poleg that I'll present shortly, she reminded me as we were working on the paper that privilege and power really shape the entire context of any intersectionality research. Just in brief, of course, there's a long history of intersectionality, beginning with Sojourner Truth's speech, and of course, it being coined by Kimberly Crenshaw. I won't read the slide due to time, and I want to focus more on the approach. But having read the speech myself, I am a woman. I think it's quite powerful. So there are a number of seminal papers, I believe, in the field, of one of which is Lisa's paper in HAPH and Greta's paper in social science and medicine. And just to remind ourselves the importance of intersectionality overall, this is a quote that I just really like from Lisa's work, from a 37-year-old gay man who said the following: "Well, it's hard for me to separate my identities. When I'm thinking of me, I'm thinking of all of them as me. Like once you blended the cake, you can't take back the parts of the main ingredients. I'm a gay man. There's also something to say about aspects about being a Black man." So there are many different intersectional positions. Again, race, ethnicity, gender, sexual orientation, geography, et cetera. I'll talk more about the geographic component in a moment. But just briefly, I think that the common two approaches are mainly used in intersectional work, and highlight kind of the pith of the talk is, mainly at the individual level, but focusing on specific populations and some type of effect modification or intersection or interaction analyses with other newer approaches in the field. So some of John's work using, for example, decomposition methods. And I think this is the common approach that people do. They have an individual level variable and an association, usually at the individual level, and they do some type of stratified and or interaction analysis. So this is what we've done as well. We look at the individual association between stress and sexual risk behaviors, find that there are some associations, including we control for meaningful covariates, and we find there's association, but then we hypothesize that this individual level variable incarceration may potentially modify this relationship due to various aspects of how one who is incarcerated may have less privilege and power in society. Not surprisingly, we found that there is actually this differences in whether someone was incarcerated or not. But my suggestion or point of this talk, and something I've been thinking through, and this is a thought piece that I've been working on for a while now, but why do we only conceptualize our intersectionality overall, but also our intersectionality measured at the individual level? So of course, we have this multi-level perspective that's been highlighted a lot in the field. Bronfenbrenner has had many different iterations, focus on specific populations, focus on specific conditions. So I just want to remind us about it. The first level is this individual level. It depends primarily on biological, cognitive, perceptual, and behavioral risks associated with acquisition of risks. If we think about one population that I study, Black sexual minority men, these individual level studies show that medical mistrust has been associated with HIV risk. In this case, medical mistrust was associated with PrEP. For example, race-based medical mistrust was associated with less willingness to use PrEP among Black sexual minority men. The second level is this network level. It can include social networks, family networks, sexual networks, and or drug using networks. We know that networks matter. There's a wide range of studies that could be presented to demonstrate this. We know that, for example, that bridgers, people who connect two different or distinct sexual networks, are more likely to be HIV infected. We also know that, this is some work from our group, that discussions around avoiding HIV with people who are close to you, so confidant members, was associated with increased greater awareness of PrEP. And much of the work that I've, at least early on in my career, done focus on the neighborhood level, which determines access to prevention resources, treatment and care services, and other types of resources that are useful to maintain health. For example, healthy food stores, parks, et cetera. It could also include air pollutants and noise. This has been highlighted in many documentaries. Tom Levis has a new documentary highlighting the importance of neighborhoods. This is a documentary that my group created several years ago. And of course, there are many books written about the salience of neighborhoods and health. This is just one of our papers, but we found, as an example, that higher neighborhood educational attainment and greater density of primary care facilities was associated with greater PrEP awareness among Black sexual minority men. Just highlighting that these multi-level factors that I think we would generally all agree with matter for health. I use the case of Black sexual minority men as one case. So what I'm really calling for is really in our quantitative work to really remember these multi-level perspectives. So I'll go through a series of models, kind of a model that we are developing / refining, and then I'll share with you some models in the field that I'm hoping to incorporate into this. And then I'll go through an R1 project and how we're starting we're collecting data, but how we're starting to approach answering these questions in an intersectional way. So this is one model that highlights that these multi-level factors matter and that they are all related to each other, but also that when we think about intersectional identities, that we need to incorporate them into our multi-level framing and or thinking, which, as I'm suggesting, is not currently the case. There are several models in the field that I think are exemplars that highlight this to different levels and different degrees. This is one model that we are drawing from. This is another model that's been published that, again, highlights that these multi-level factors matter when we're thinking about intersectional analysis. This is another model in the field. And finally, another model. So we have a cohort called N2. We're currently in our second wave of our cohort. We started recruiting in September of last year with a large focus on substance use and sleep. Our models there, which highlights these multi-level factors and in some ways intersectionality. Just in brief, we're sampling from our previous round of data collection, our previous cohort. In Chicago at the time, we had 412 participants. We're currently sampling 600 Black sectional men in the Chicago area. This is just some pictures of our initial recruitment events and flyers of our events. So AIM-3 is what I'm really focusing on. So in this project, our third aim is to evaluate associations between sleep health and HIV care by levels of obesity, so looking at individual level interactions, and then by levels of obesity by each of these multi-level factors, so looking at cross-level interactions in the association between sleep and HIV care. And just briefly, I think that we need to do this work, but there are challenges, including collecting data at these different and sometimes complex data types at these multiple levels, thinking through and making sure that there are sizable and thoughtful samples in each of the strata across the different levels and different variables. And just mainly suggesting that we need more research looking at multi-level intersectionality, which I really think will help inform more comprehensive and effective interventions. That's it. Thank you.
So do we have any questions? Thank you so much, Dr. Duncan. Questions for Dr. Duncan?
I have a question for Dr. Duncan. Hi, Dr. Duncan. My name is Wynn. I'm a postdoc with the Pride Study. My question around multi-level perspective for intersectionality has to do with thinking about sort of different measures at different levels and the amount of variance that those measures explain at those different levels. And so how do we then sort of think about meaningful measurement at those different levels when there is a greater likelihood that measures at some of those interpersonal individual levels are more likely to explain some of those variances in individual level health outcomes?
Okay, Wynn, so just so I understand the question is basically you're saying that much of the variance explained is due to individual level, and it sounds like there's a little bit of pushback to say that at these other levels you expect that the variance explained may not be as much, so we need to consider that, or maybe we should account for that or quantify that. Is that the question?
Yes, and also I guess in just some of the work that I've worked on, when we incorporate both interpersonal and sort of structural measures of discrimination, we find that oftentimes a lot of that variability is being explained at the interpersonal level. But when we think about sort of on an absolute scale and not a relative scale, it's particularly for structural measures, even if we see a small effect size, it could be affecting a large number of people. But oftentimes trying to explain the complexity of what we see in the effect versus what we anticipate the impact of structural measures I find that to be a bit of a challenge. So I'm just hoping that, or we can talk about this sort of after Dr. Bauer's presentation, but sort of trying to tackle some of those challenges in terms of evaluating measures at sort of different levels, and sort of what do we do when our results sort of doesn't match what we sort of set our assumptions to be.
Okay, thanks, Wen. I think kind of my point is from this particular talk was that I haven't quantified it, and there hasn't been any kind of a scoping review to my knowledge, that the vast majority of work, I'd say 85–90% of the intersectionality work has looked at one single level generally, and then two, most of the work has looked at mainly the individual level, but yet there's this kind of whole other adjacent / complementary or sister or brother literature that highlights that these multiple levels matter. And I just kind of wanted to show the example of that through kind of one particular population. And I guess I would say that from a quantitative or perspective, even if we may see more variance explained in an individual variable. So for example, individual level discrimination, but we would anticipate that there can be or may be some that structural or policy level discriminatory factors may also explain some of that variance. And kind of my point is that we should make sure that we include both levels in an intersectional analysis.
Dustin, I do want to follow up and ask you a separate question. In terms of your work around neighborhood analysis and with the various measurements that might be available, I'm wondering, as neighborhoods are rapidly changing, partly due to gentrification and other or flight in terms of people moving in and out, how does one keep up with conducting neighborhood analyses with that frequent fluctuation per se of people in and out of those neighborhoods?
It's a great question. I think it depends on there are measures we can ask people for in terms of like their level, the duration of time they spend in their neighborhoods, and or how long they lived in their neighborhoods, or put differently, how much exposure we would anticipate. So there may be different levels of time, for example, that someone has lived in a neighborhood, and we can account for that in our analysis, and our group often does. So for example, we can ask people how long you've lived in your neighborhood. There are different metrics, and we wrote about this in Neighborhoods and Health, and there are many kind of like complementary texts that have described just a range of ways we could, characterize various neighborhood exposures. But one of the simplest ways is just asking about, how long someone has spent in that neighborhood, and of course, getting some type of temporal data on movement or residential history.
Anissa?
Well, with that, I think we will actually probably save any remaining questions for our discussion at the end and move to our final presenter. Paul?
Yep, great. It is my pleasure to introduce our final presenter, Dr. Greta Bauer, who is a professor and director of the Institute for Sexual and Gender Health at the University of Minnesota Medical School. She holds the endowed academic chair in sexual health. Prior to November of 2022, Dr. Bauer was a professor in the Department of Epidemiology and Biostatistics in the Schulich School of Medicine and Dentistry at Western University in London, Canada, where she held a sex and gender science chair through the Canadian Institute of Health Research. As an epidemiologist, Dr. Bauer's research has been both substantive and methodological, with a focus on social marginalization. She is a leader in quantitative research methods for the study of marginalized communities, including applications of multidimensionality and intersectionality in population health research. As an interdisciplinary epidemiologist, she has published in top academic journals across medicine, public health, psychology, social science, sexual health, and epidemiology. And on a personal note, it is just an absolute pleasure to be able to introduce Dr. Bauer today, as it was her 2014 social science and medicine paper that really launched my academic interest in intersectionality. So with that, Dr. Bauer, the floor is yours. You're still on mute, Dr. Bauer.
Oh, I hit the unmute, but there we go. Okay, here we go. And so like Dr. Duncan, I have chosen a more conceptual kind of framework for today. And it's because I think, as epidemiologists, we often don't get, well, we usually don't get a deep grounding in theory, and we pick up theory as we go along. And I've seen theory emerge into our field in ways that are kind of brought in through like a bottleneck almost, where it comes into the field through a particular person and people don't go back and read the original theoretical work. So I wanted to really talk about how deeper engagement with intersectionality challenges our field by drawing on a few core concepts from intersectionality theorists and scholars, and asking what they mean for common practices in intersectionality, or sorry, in epidemiology. And I'm going to start with intersectional relational co-formation. And so Patricia Hill Collins writes a lot about relationality as one of 6 core ideas in intersectionality. And within relationality, she actually writes about 3 different approaches to this. But relationality is about how we bring together things like race and gender, or racism and sexism, and how we approach that bringing together, that relationality between those things. And relational co-formation, I'm glad Dr. Duncan's already brought in Lisa Boleg's participants' quote about how once you've blended the ingredients, you can't take it back, because we're baked together, and that's what co-formation says. So the first quote I pulled out from this chapter in her book, she talks about these 3 approaches: addition, articulation, and co-formation. So it's one of 3. And these are starting points for relational thinking. They're not endpoints for analyzing it. They're tools. She's giving us tools to approach our thinking on intersectionality. So co-formation, one of these 3 tools to approach relationality, posits a holistic analysis of a seamless process of mutual construction of race, class, and gender as phenomena. And I would extend, because intersectionality scholars have, I would extend race, class, and gender to encompass sexual orientation, indigeneity, disability, and many of the other axes that we function along, that intersectionality scholars work along. And so the idea of co-formation is that it's baking that cake together, that we're embodied human beings and not ones that can take ourselves back to our main ingredients. And so if we look at the methods in our field, then we have to ask ourselves, what does it mean if we treat people as though they're embodied? And what it means is that when we bring together, for example, not just these things that we sometimes call identities, whether or not people identify with them, but we bring together these processes of oppression. If we bring together racism and sexism, for example, it becomes constituted in a way that might produce something different for people at different intersections. So we can't talk about gendered racism, for example, as though it's one thing, because the way that racism is gendered, the way that sexism is racialized, is different for people at different intersections. So I wanted to give you an example from 2 existing studies that both develop measures and validate those measures, both on gendered racial microaggressions. The authors are even using the same language around this, and both on women, but one is for Black American women and one is for Asian American women. So both American women, same construct. And when these groups of authors do their development, do their validation, they both end up with 4 subscales, 4 factors in their factor analysis for these scales. But if you look at them, you'll see that conceptually, these are very different things, even though we're talking about gendered racial microaggressions in American women, because the way that kind of racism is gendered plays out very differently for different racial groups, even within the same country. So for Black women, we have the assumptions of beauty and sexual objectification, silenced and marginalized, and two stereotypes, the strong Black woman and the angry Black woman. And these have items like, people thought you were angry even when you were speaking in a normal voice or something like that. And they capture these, whereas for the Asian American women, the ascription of submissiveness, the assumption of universal appearance, fetishism, and media invalidation, which is items that are primarily about television movies, actually. And so you've got the same construct, theoretically, the same language, American women, two different racial groups. And you can see looking at this, that it's co-formed in ways that are different, that these are quite different things that are being measured. And it wouldn't make sense to reverse them. It wouldn't make sense to have that submissiveness for the Black women, whereas you have the strong and angry stereotype for the Black women, right? And so this is co-formation, not just of identities, like it's sometimes talked about, but of processes of oppression as defined in different ways, in a way that only makes sense for a particular intersection and thus can only be measured for a particular intersection. So this presents a challenge for us in epidemiology because we're, I think, sometimes caught up in, I won't say people put different values on it, but you have these whole population studies where we have the potential to look across so many intersections, and yet we have things that can only be measured in particular groups. And then we have these subgroup analyses that might be intersection specific, where we can go very deep and we can get at the specificity of experience. But there's a problem in how that may or may not be able to really explain the types of inequity we see across a population. And so I'm going to bring us to Leslie McCall's ideas of categorical complexity. And then I'm going to come back to that kind of challenge to our field that's created. And then at the end, I want to talk about anti-categorical complexity, because we largely just ignore that and pretend that's not really a thing, because we have to pragmatically accept categorization and the kinds of things that we measure. So Leslie McCall has this formative 2005 paper. Complexity is one of Patricia Hill Collins's 6 core ideas of intersectionality, but I always find myself going to Leslie McCall to get at the complexity of intersectionality. So what I was talking about with the co-formation there, with Collins's co-formation, produces things that can only be measured intracategorically, with intracategorical complexity, where we're looking at a particular intersection. So intracategorical complexity in the middle, it focuses within social categories, often at under-researched intersections. So we're saying, okay, how does gendered racial microaggression, how does this play out for Asian American women? How does that play out for Black American women? And we can get at that complexity. In epidemiology, some of the descriptive studies we've been talking about are usually looking at intercategorical complexity. They want to study, or we want to study with our large databases. And I think this is a strength of epidemiology. I think it's something that we have to offer to intersectionality, because we can study many intersections, including frequently understudied ones. But in intercategorical complexity, we're studying experiences of inequality across social intersections, not just within one, but we're looking at the disparities across them. In anti-categorical complexity, which as I said we often ignore, we're deconstructing the social categories themselves, and we're considering that social life and status are fluid and multiple, also socially and historically contextual, and are unable to be captured in categories. And so that I'll return to at the end as my last challenge for our field. With regard to the intercategorical, I know this is a block of text from one of my papers, but it's something that I wrote and I've been thinking about a lot since, and I don't have a solution for. So this is what I'm talking about today to challenges, is that I wrote, we think it's no accident that statistical analysis methods have focused on intercategorical complexity, where measurement methods have focused on intracategorical complexity. And I've done a systematic review on papers in the field, as has Paul Lussett, Wesson's group. And it really is true that the measurement work in this field of intersectionality and quantitative research is largely intracategorical. The statistical work is largely intracategorical. So what's the challenge here? So Evans notes that most studies of social processes that generate inequalities have also been intracategorical studies. So we can look within Black American women and gendered racial microaggressions, and we can say, okay, within this one intersection, do differences in the level of these gendered racial microaggressions is that associated with our health outcome? Might that play a causal role in generating our health outcome? But we're looking at there is inter-individual variation just within one intersection. That's not necessarily going to help us explain differences in outcome between that intersection and others. And I highlight here, I've underlined, it draws on one of Sharon Schwartz's classic papers called Type 3 Error, the right answer to the wrong question. And while that language for Type 3 error didn't catch on, I think multiple authors have used it. The issue of conceptual dilemmas within it is bang on. And one of them is that studies of inter-individual variation within a particular subgroup, she doesn't say intersection, but for our purposes, they suffer from conceptual bias when the goal is to inform knowledge of what causes inequalities between that subgroup and others. So if we have something that's universal, like gendered racial microaggressions for Black American women, we can look at variation within that may give us some information, but it's not going to inform what generates differences in outcomes between that intersection and others. And furthermore, how are we going to study that when we have a measure that can't be measured across different intersections? And so I say this is a response to some critiques, including one written by John Jackson, to a couple of other papers we wrote. So we're so many deep in a series of critiques and responses at this point. And so we say this is precisely what we're trying to do when we were developing these intersectional discrimination index measures. But the measures that we were developing that were designed for intercategorical analysis, they lose some of that specificity of those intercategorical measures. And that specificity itself might be a really critical part of what's generating those inequalities. So this is, I think, a major dilemma for our field that I've been thinking about ever since I don't have an answer to, because how do we really get at what generates disparities across intersections when so much of might be playing a causal role is what Liam Kofi-Bright sometimes calls switch intersectionality, that there's particular pathways that might only exist, like you're flipping a switch, they might only exist for certain intersections. And we haven't really solved that. So I put that out as a major challenge to our field. When we want to really understand what's driving disparities, we need to understand things that can be conceptualized and measured across groups, but also the very obviously important processes that are specific to different intersections and may only be measurable at those intersections. So I'm going to take us back then to anti-categorical complexity as a further challenge. So there's this inter and intracategorical issue that relates to co-formation. But if we turn to anti-categorical complexity, again, pretty much ignored in our field, it considers that social life is irreducibly complex, overflowing with multiple and fluid determinations of both subjects and structures, to make fixed categories anything but simplifying social fictions that produce inequalities. And a lot of us will acknowledge this. It's a kind of, I'm going to put that in my limitations section kind of thing. But she says, the reason why categories and the social relations they articulate can be deconstructed in the anti-categorical approach, which by the way is almost always qualitative, is precisely because they can be shown to change across cultural and historical boundaries, that is, to have no underlying essence. Or to go back to Patricia Hill Collins to say that they're co-formed, that there's something that's very specific to not just, the way that we have this relationality between categories, but also to the social and historical context into which those categories are combined, that co-formation happens, and the way that meaning is created, the way that structures are created, and the way that that impacts life. So I want to kind of suggest that we as a field should explore a bit more anti-categorical complexity. And it's something that I've done in my work, and I haven't called it that necessarily. I've usually called it multidimensionality when I'm writing, because I think anti-categorical complexity is a little bit bigger. But I want to throw this out there because we often talk about intersectionality, and the language of identities comes into our intersectionality speaking. And yet we're often not talking about identities. We know that most of the social positions, the social variables and categories that we measure are not necessarily identities. Sometimes they're behaviorally measured. Sometimes they're measured in different ways. Sometimes they're about a social position that's not an identity. Like you don't have to identify as poor to be impacted by poverty. It's a social location, not necessarily an identity. And some of these you'll notice are very much socially and culturally situated. The label of lesbian identified people, for example, or visible minorities is very specifically a Canadian term used by Statistics Canada because it's defined in the Employment Equity Act of Canada. It's a very, not just socially and temporally specific, but a legally specific definition. And so we wanted to know if there are other ways to better measure that. And so I want to put just a plug out there for everybody as we're going along to really think about what we can do quantitatively in terms of anti-categorical complexity, other than just acknowledging the limitations of our measures. Can we acknowledge when we're using a proxy measure for something that we really want? That might be a different dimension of sexual orientation, of race, of ethnicity. And can we consider whether in fact that is a reasonable proxy measure? So I give that to you as a final challenge. So my challenges for today are that processes of oppression are often shaped in intersection-specific ways, which will not be measurable across other intersections. That we have this tension between intersection-specific, intercategorical processes of oppression and analyzing factors that may drive inequalities across intersections or intercategorically. And the importance of giving serious thought to categorization in a context of identities that are multidimensional, as well as culturally and historically specific. And I'll say that as a field, we do a much better job, I think, at considering validity of the measures that we use that are not social categories. We'll spend a lot of time validating and researching psychometrics. We spend very little time actually validating and researching the social categorizations that we use. So those are my challenges for our field today. Thanks. Or for my field. I'm not assuming everybody here is an epidemiologist, though many of you are.
Wonderful. Thank you so much for that talk, Dr. Bauer. Does anyone have any questions related to that talk before we jump into our panel discussion? I have one quick question, or maybe it's a comment, which is the example that you gave about gendered racial microaggressions. I thought was a really fantastic one, but also gives me a sense of unease around our general practice as epidemiologists in treating so many variables as common, even though we know that if we peel back the surface, there are these differences intercategorically, especially with, for example, say mediation analysis. And I think it's really thought-provoking of this idea of switch intersectionality, that some mediators, some experiences are only applicable to certain groups. In your viewpoint, does that invalidate large swaths of analysis that we do as epidemiologists, that we're sort of overgeneralizing these questions and associations?
Well, so I've been asking myself whether even some of the common measures that we use really have good, not measurement invariance, but kind of construct invariance, whether they actually mean the same thing across different intersections. So gendered racial microaggressions, you can imagine, is going to be structured around gender and around race, right? But even when we look at common measures like depressive symptoms, are we actually capturing the same thing across different intersections? And I use that one because there's some evidence that for older men, for older Black men, that it may be not capturing the same things, that there might be kind of intersection-specific aspects of depression. And that may be why depression is less predictive of suicide attempts in those groups as well. And, from my work with trans and gender diverse communities as well, I've just often wondered, I'm fairly sure that the CSD, for example, captures some aspects of gender dysphoria that probably make the final score on it related to major depressive disorder in a different way than it would be in cisgender populations. I don't have evidence of that, but I know, from just conceptually from, working in community for a lot of years and looking at those measures, I don't know that it's specific to depression in that way, especially where communities have other types of social stressors and conditions that may lead to some of those same sleeplessness, all the other types of things that that fall under those depression measures. So I have this question across a lot of kind of the basic things where we give a measure and we say this is well validated in multiple populations. I think, and I've said this many times, I'll say it to this group again, there's a whole career for somebody to make in intersectional studies of measurement invariance for common measures that we use in research. And then we can get back and answer your question, Paul, and we can see whether there's evidence that what we're doing has made sense all along, or maybe if it hasn't.
Great. But before I turn over to Caravella, I hope I'm pronouncing your name correctly. I also just wanted to make an announcement that we will share slides with the audience afterwards. I know there's a lot of information to process and digest over the past hour. Caravella?
Yeah, thank you. Thank you for the presentation, Dr. Bauer. I'm really interested in this idea of like switch intersectionality, and it made me start thinking a little bit about the fluidity of intersectional identities, even within an individual. And I know from going to some of the research salons that you have that attribution sometimes can't be really, it's not always really helpful. But I started thinking of this idea of like salience of parts of identity, and, like walking into a room where you're the only woman, or walking into a room where I'm the only person of color, and like parts of my identity might become more salient in those like times. And so like, is there a way to quantify like to measure that, like kind of salience in this like anti-categorical way? Like, and again, I'm new to intersectionality, so if this question is not making sense, please help me. But
no, it's totally making sense, because you're talking about a few different things. You're talking about life course and developmental processes too, right? Where fluidity is a part of it. And we're often, measuring these at one point in time. And sometimes in our cohort studies, we don't even remeasure things. We just assume that those baseline measures are going to hold across the time period of our study, right? So that's one thing. And another, this kind of salience, you're talking about that shift where you're in one context, one identity or one social location becomes more relevant. In another, it's another. If you're not familiar with Philomena Assad's work on everyday racism, she very nicely kind of explains that process. It's from 25 years ago or something, but really very, very good at explaining that kind of process. In terms of measurement, there's a couple of things. There's measuring at different points in time so we can capture those shifts. When you look at identity theory, there's a whole body of literature out there on identity that includes not just salience, but identity centrality. There's all of these different dimensions to identity itself that there are measures for, that measures could be developed for. And then the other is paying attention to some of the processes. So we've developed a scale that we haven't validated yet on one of my projects called, it's called the ISM, it's the identity siloing measure. And it's a bit of what you're talking about. It's the work that people do to navigate multiple marginalized identities. Like it's the work, like whether it's for safety reasons or because it's just too exhausting, or but it's about, depending on who I'm with or where I am, and it's about change my accent, I dress a particular way, I don't talk about my family, all of these kind of things. So it's related to code switching in a way, but it's not just linguistic, and it's related to identity non-disclosure, but it's not just non-disclosure. So we're trying to develop something to just capture like just the burden of that work that people do, which is a different thing as well.
Thank you.
Greta, good to see you again.
Hello.
I wanted to ask you a follow-up question to that in terms of social advantages and disadvantages, and how do you capture the nuances between the two? And I'll give you an example. So in academic medicine, a white woman might be advantaged being white, but disadvantaged being a woman in terms of progressing through the academic ranks. Yeah. And the same thing could be said for a Black man who might be advantaged in terms of being male in the academy, but being disadvantaged of being Black and male in the academy. And I'm wondering that quite nuance, how do you pick at that in terms of using an intersectional lens?
So my tendency is to think that advantage disadvantage doesn't really play out in intersectionally in the same way. Like you can't say whether something's an advantage or not might be dependent on other aspects of that intersection. And so like, is it always an advantage to be male? if you're dealing with, a visible mental health issue or something, then being male and also being Black, for example, being male is not an advantage in that situation, where people might perceive, somebody as more angry or more violent and react accordingly, right? So I think, in one of the CIHR, Canadian Institute of Health Research, kind of meet the methods thing they did for me, we did this variation on the wheel of power and privilege, or, and I made a point that we had to put in there that wasn't intersectional, because whether something is actually an advantage or a disadvantage is something that I think is subject to be more or less so, and maybe even in the opposite direction in particular contexts. And that's why I think, the ideas that people had early on about adding together advantages or disadvantages to create some kind of metrics, intersectionality says it doesn't work like that. It's not additive in that way. And co-formation says that when we put these all together, we produce something that's entirely different potentially, that can't just be added together from its parts. And so if we start to think of this advantage and disadvantage, there's situations where it's been an advantage for me to be queer, and there's situations where it's been a disadvantage in different contexts and in conjunction with other parts of myself, right? And so I think intersectionality helps us to be a lot more nuanced about that, but also, suggests that we have to take that approach of co-formation.
Couldn't agree more. Thank you so much.
Also like to open up that line of questioning to the entire panel, because this has come up as well with our community panel, this idea of salience and how in some contexts, something, a certain attribute or axes of identity might be considered a strength, might be considered protective. In other contexts, it can be considered a threat, and how context matters. And we often, particularly in epidemiology, struggle with capturing that nuance and see things as more fixed and look at those overall general effects or associations. And I'm just love to get the perspective of the panelists in terms of how do you incorporate that perspective of salience and of context as you are conceptualizing your studies through the lens of intersectionality and trying to capture that complexity of the lives of the communities that you work with.
I guess I'll start. I think for me, just from a big picture perspective, like a lot of my work has been trying to do epidemiology for health equity in a way that doesn't necessarily mimic what we would do when we think of causal effects for exposures, and sort of repeat some of those same things. And I think one of the fallacies that we often bring into the work that comes from a sort of a treatment effects perspective is this notion of generalizability, and seeking to find an association that is the same everywhere in all contexts, or one intervention that's going to apply for everyone, that's going to fix it for all contexts. And I think that's a fallacy. I think ultimately the interventions are going to have to be local, tailored, contextualized. And so I think I would approach, setting up a study with that, at the outset, that, I'm not trying to produce something that will apply to the entire US, or that will apply to every state or Canada or the entire world. It's like, no, here in this healthcare system or whatever, for this population or for this particular outcome, these are the inequities we find, and here are sort of the things that we think are driving it. That's why I really, I know it was a very mathematical talk, but the beauty of that conceptual framework is that it allows for that flexibility, right? So you can choose the scope, you can choose where, and you're not trying to find some universal causal effect. You're trying to talk about inequities that are contextualized, that are rooted in specific places and times. And so that's, I think, in my view, it's more of a framing issue. I guess I'll stop there and let Dustin or Greta pick up.
I mean, I'm not sure I have much to add other than I think it's a great question, Paul, and we don't necessarily anticipate something will have ubiquitous positive effects. So put differently, I anticipate that there may be effect modification, for example, by geography, and or put differently, either in my sample or rather the analytic sample, and or kind of overall. So just a quick kind of thought experiment that we haven't really thought through, but like I'm just thinking about social capital. Social capital could have, or social networks, they can have positive effects in terms of HIV prevention and care, but networks in social capital can also have negative effects. I'm thinking about places like in the Deep South, where there may be laws that laws and social norms that may not be health promoting for HIV prevention and care. So I guess to summarize, I'd say that our group we explicitly recognize that not all structural factors, or not every association may be in the way or the direction that we anticipate and or expect. And I think John's point about generalizability is so well taken, not just kind of from a sample perspective, but what the association means in that particular setting. And I think I appreciate the geographic context, but also like the timing dimension, which we also don't talk about, I think, as rigorously or thoughtfully as we could and or maybe should.
I'd love to build on this for just 1 second too, because I think this, the idea that the social, historical, and temporal context is important is actually, I think really a major strength if we approach the work a little tiny bit differently. So Patricia Hill Collins has this other idea of saturated sites for intersectionality, which are areas where that kind of interconnectedness of systems of oppression is so intimately linked to experience. For example, in the study of violence, as she says, people don't go willingly to their assigned places. And so she says, if we study these saturated sites, we have the potential to, and these are my words, not hers, but to kind of turn the mirror back on society and to understand the interlocking systems of power in that society at that particular point in time. And so if we embrace the social, historical, temporal specificity and situatedness of the things that we're studying, and we say, this is actually exciting because for a lot of the things we're studying, family, a lot of aspects of health, violence, but a lot of these things, when we understand how those are patterned, it helps us understand how social power is patterned. And we don't usually take it to that point. We say this reflects it, but we don't say, what have we learned about social power from the ways that we study these things? So I think we could embrace it and go deeper into that rather than have that as a limitation.
Thank you. I have several questions to follow up. I don't want to monopolize the air here, so want to quickly open up to any of our other audience members if there are questions to follow up on that.
Or even new questions. And you can also put them in the chat if you don't want to speak up.
While we're letting people ponder, I'll just quickly follow up on that and maybe even also shift us in a new direction. So the last thing that you mentioned, Greta, is in terms of looking at how these things are socially patterned can also give us insight into how power itself is, learn more about social power in a society, which if we talk to Lisa Bollig, for example, remind us that that is the ultimate goal of intersectionality. It's about praxis and about action. So I'm curious about if and how all of you think about how your methods translate into understanding, going beyond documenting disparities to understanding ultimately how power is patterned in society and moving into that place of action. And then slightly relatedly, but perhaps a pivot point as well, is another point that was raised during our community panel was about this focus on deficits, and that's something that we often do in epidemiology as well, is document risk, document disparities. But what would it mean to instead flip that and focus on documenting assets and deconstructing assets within a community and how to live more positive, more healthier life? Like, is that just a matter of inversing the way that we code the outcome, or is there sort of more thought that goes and complex thought that goes into designing the overall study to focus more on assets than on deficits?
Yeah, sure. Unless someone wants to jump in before me, maybe I'll take a quick stab. Yeah, this is a tough one. I think power is so challenging because there's like different levels of power, different forms of power. One, I think in my work, I've kind of looked at two levels of intervention. And I would say, you know, in the work that I've kind of been working to help build, it's a lot been sort of like interventions that could be built to address specific things that marginalized groups are facing in terms of barriers or which you might think of from a deficits perspective. I think then there's also sort of like, you know, there's the structural approach. And I realize that, you know, there's a heavy emphasis on structural approaches right now, and I agree with that. However, at the same time, you know, just from my own lived experience in, you know, experiencing these things in a very real sense, people need solutions now, right? So people need interventions now. And so the structural work will take a long time, but we also have to build interventions for people who are in their 50s, you know, who we might not reap the benefits of restructuring the education system. And so we need to sort of walk and chew gum at the same time. And so I've chosen to build methods that could help us deal with people who have embodied deficits and barriers now, so that we can help address some of those issues. And I don't really see the work as mutually exclusive. Some of my other work that I've been doing, which isn't published yet, is working more on evaluating policies from a meaningful perspective, which I hope will be more along a structural line of things. The challenge there is a lot of the policies that we have are bad. So the real question is just like, how do we come up with policies and structural interventions that will actually, you know, redistribute power? That will, you know, how do we sort of inform those things? And I honestly don't have a necessarily great answer yet. I think it's a really difficult challenge. In terms of deficits versus assets, again, this is an area where I think we should have both in mind. So like, you know, I think there are things about marginalized communities that sometimes built up that are very beautiful and powerful, and aspects of culture that have really withstood really heavy forms of oppression. And I think it's possible to do causal inference on that. You know, within group studies are a great way of going about doing that, seeing how variation within that might improve outcomes for those who maybe don't have as much assets. But I would push back and say, like, one thing I've always been a little hesitant with, like a lot of like resilience frameworks, is I feel like, you know, being a marginalized person is hard enough. And we don't want to ask them to be more resilient. You know, what we really need to do is to address the structures that are marginalizing and placing barriers in their path. So I think to the extent that maybe, yes, we can do more of some things or leverage things or highlight things, I think that's a good thing. But I also think we do have to like sort of not ask people to be exceptional or superhuman in terms of what they're facing on a day-to-day basis. And I know that wasn't your question, but this is just sort of me speaking to like the broader theme of like resilience. And, you know, I mean, I've seen some of the effects of resilience on family members, and after a while it can take its toll. but I think the deeper question that you're pointing to is, which I think is an excellent one, is how to do this work in a way that doesn't frame marginalized communities as completely barren or negative or always challenged. And I think that's well worth thinking about. I don't know if it's a methodological one as much as something that we just have to invest more time into, with respect and care, how we portray, how we frame the communities that we are working to support. So I think that's a beautiful thing to pursue, that maybe we should do more of. And maybe in public health, it's not just about sort of identifying the risks, but doing studies to highlight benefits, as you say. Yeah. So, yeah. I hope all that made sense.
Yeah, absolutely. I think so. But before we move on to Dustin and Greta, I do want to point out a question in the chat. I know we have about a minute or two left. So this was from Brittany Gideon, asking, how do you recommend current graduate students or early career investigators to integrate more intersectional ideas or methods into our own research? And how can we create research questions that holistically integrate intersectionality?
Greta, do you mind if I make a quick point? Okay, awesome. I mean, maybe the answer to the second question would be their resources. You know, Greta and Lisa have this kind of wonderful training institute that many of us have attended, and I think that there's a series of adjacent or related seminars that I found helpful, and perhaps you will as well. But just I just wanted to talk about the assets piece, because I think unintentionally we further stigmatize communities, particularly mostly marginalized communities, I'm assuming it's mainly unintentional, but I just want to kind of name that. And then I think public health students, or like when students enter public health, I think they get frustrated that many things are just so deficits oriented in how we approach our science. This is bad, this is bad, this group is even worse, kind of thing. So our group intentionally, so I'll say maybe kind of honing in on my neighborhoods work, I focused mainly on two factors: neighborhood violence, which of course is a deficit, but also assets, in particular social capital within the neighborhood level. And I've been quite intentional about that focus, partially because I want to make sure that we don't always approach things from a deficit standpoint, but then kind of circling back or looping that in with kind of intervention work. I just submitted a grant to kind of build social capital within a certain population, in this case, Black African sexual minority men, to improve social cohesion, social trust, and those things. And I think that it takes some intentionality on our part to start thinking about other aspects of communities that are not just negative things. There's a wide range of course, positive attributes of communities that we could learn from and potentially leverage including in our intervention work. And so I want to make sure Greta has some time as well.
I think that's a good way to go out.
Great, thank you so much for that. And I know we have a question, but we're unfortunately at time. So just to be respectful of everyone's time, I'm so sorry, Anya, if I'm pronouncing your name correctly. Maybe we can turn it over to Orlando, who I believe will close us out.
Thanks, everyone. And thank you, Greta, John, and Dustin, for really coming and sharing your insights on intersectionality and using intersectionality in quantitative methods. And I want to thank everyone else for also showing up today as well and partaking in today's discussion. We will make the recording of today's session available and will be posted on the CFAR website, as well as the speaker's presentation as well. So many thanks again. We look forward to seeing you in the fall. Be on the lookout. We do have a survey that we'll disseminate in the coming weeks or so around the SWGI, intersectional SWGI, that will come out in a few weeks, and we hope to get your responses so that we can make this SWGI better. So thank you again, and please have a wonderful, wonderful Wednesday afternoon.
Thank you, everyone, and thank you to our speakers.
Thank you all.
Thank you so much, Dr. Jackson.